friendly fire, please. Yeah.
Okay, I think Anand, are you coming on, or someone, or should I just start off? I think we should start off. Okay, all right. Okay,
Thank
okay. Good evening, and I'm back, boys and girls. So after the absolutely scintillating sessions, and Rohit always sets the bar so damn high. It's so difficult. Now, in the same way, now we are getting into a debate about primary demyelinating disease, multiple sclerosis. And you all know that there's been such humongous advances in our understanding of the pathophysiology of MS that we have really expanded armamentarium. As against 1993, now we have 23 agents which are marketed with 10 different mechanisms. I hope you all know there are 23 different drugs which are now marketed for multiple sclerosis, and that's huge. It's so along with the super elegant, very selective immune strategies, you have broader immune modulation, you have regeneration, you're trying to revive a dead tissue. So it's really exciting time to be in. I think when we have to manage the people with multiple sclerosis. So, but center to this, I think, is the main concept that we now know that there is a switch, that in primary multiple sclerosis it's inflammatory, and then there is a switch and it becomes inexorably progressive. That's degeneration, and we don't want that switch to happen. And it is in this regard that you have the concepts of induction and escalation, the pyramid and invert the pyramid. So we have a debate now. There are two brilliant neurologists who are going to take on this. So first is Pranjal, who will be talking about induction, and then we have the escalation person who's going to debate why we need an escalation therapy as a first strategy for MS. So these two guys will have to deal with the three main questions as why and when and how. Okay, over to you, Pranjal.
Okay. Yeah, so good evening, everyone. So the topic of today's debate is my best approach to MS management, and I'll be speaking in favor of induction. So as we know, the therapeutic landscape of multiple sclerosis is rapidly evolving. From no drugs till 1993, now we have plethora of drugs in our arsenal to treat multiple sclerosis. And different treatment paradigms are employed by neurologists all over the world. One is escalation, the other being induction. So induction strategy, as we all know, the drug is administered, and it is present in the body for a small amount of time and exerts a prolonged effect on the immune system, and thereby having a long-term therapeutic clinical benefit, which can even lead to permanent drug-free remission. It resets the immunological system to prevent the phenomena of epitope spreading, which can result in better control of the disease activity. It sort of rebuilds a new and healthy immune system with a different repertoire of lymphocytes and potentially re-establishing immune tolerance. So as the idiom goes, strike while the iron is hot. Traditionally, we have seen MS has been regarded as a two-stage process where the initial phase is characterized by marked inflammation and which represents a relapsing phase. It is this phase where our DMTs are active and exert an influence on the disease course, as opposed to neurodegenerative phase, which is characterized by irreversible progression and there is very little inflammation. Until date, we do not have any therapy of note which can really change this neurodegenerative phase. And as Madam always says, that there is a switch which happens. And since we don't know that when that switch happens, so it is important to treat the disease when the disease is ripe, and we need to use the best place for the management of our patients. So in this cartoon, we can see here that the brain atrophy starts very early in the course of illness, and perhaps even in the preclinical phase, and occurs at a much accelerated pace as compared to normal aging. By using escalation strategy, we are losing precious time, and also the neural reserve also keeps on declining as the time goes by, thereby pushing the patients to a progressive phase where we cannot do much for the patient. And also we know that early course frequent relapses and shorter interact period are one of the strongest predictors of disability. So it is important to treat them early and to hit them hard. So these are the agents which we use for induction. As Madam said, that their strategy is to flip the pyramids, and the drugs used are mitoxantrone initially, and after that we've had cladribine, alemtuzumab, stem cell transplantation also. So this is the biological premise of using induction therapy, and to substantiate that, we do have data as well. So the real world data, this was a study which was published in Lancet Neurology in 2020 recently, which looked at the patients who had
Pranjal, yes. Go little slower.
Yes,
Okay.
Yes. This was a study which looked at the patients who had received high efficacy therapy, and they were dichotomized into patients who had received it early, which was defined as 0 to 2 years, as opposed to late, which was defined as 4 to 6 years. And we can clearly see here that the patients across every year from 6 year onwards, the EDSS score, which is a marker of disability, was much lesser. It was statistically significant as well in patients who were started on early high efficacy therapy. And at the end of 10th year, the mean EDSS score was also 2.3 as compared to 3.5, and which was also statistically significant. They also looked at the disability progression measured from 6 year onwards, mind you, when both the set of patients were on high efficacy therapy. So we can clearly see that the hazard ratio was 0.38 with a very narrow confidence interval, the result being highly precise with a statistically significant p-value, a very robust result. And so this shows that to harness the best therapeutic benefit of these high efficacy therapy, we need to start the patient on these therapy early in the course of illness rather than late. So this was again a study which had presented the data from Cardiff, Wales, which was published in JAMA Neurology, which pitched patients against who had received early intensive therapy against patients who were started on escalation therapy. So the primary outcome was 5-year change in expanded disability status scale score, which was significantly lower in patients in EIT group, and even when it was adjusted for relevant covariates. And also the time to sustained accumulation of disability was also was higher in patients who were started on early intensive therapy. And also they concluded that long-term outcomes were more favorable following early intensive therapy. And an important thing to note here is that the patients who are on early intensive therapy, 18% patients got pregnant, and none of them had adverse outcomes. So we do have randomized controlled trials as well. So these are the Alemtuzumab studies, CARE-MS1, CAMS primary analysis, the extension study where treatment-naive patients were given either Alemtuzumab or interferon. We can clearly see here that the annual relapse rate was much lesser and was much lesser in patients who were started on Alemtuzumab as compared to interferon. Similarly, the sustained accumulation of disability was also lower in patients in Alemtuzumab. The long-term data is also important. So we can see when these patients were followed up to 12 years, the good effect was maintained with annual relapse rate being 0.09, and the EDSS changed 71% even after 12 years had either improved or stable EDSS. 69 patients were free of MRI disease activity, 34% patients achieved NIDA, and 73% received no more than 3 courses over 12 years and were off DMTs. So this was the Clarity trial, which established the efficacy of cladribine as an induction agent, hematopoietic stem cell transplantation. So this was a meta-analysis which was published in Neurology Green. So we can, when these patients who had received autologous hematopoietic stem cell transplantation and were followed up to 5 years, a whopping 70% of these patients achieve NIDA, which is the holy grail of MS treatment, and that is what we all strive for. And none of the DMTs can offer that kind of disease control. So to conclude, induction therapy can be given as one of our pulsed short courses, which leads to high adherence. It has proven high efficacy, and we do have long-term data as well, and it induces long-term remission and the possibility of cure and the possibility of being off DMT completely, which is quite luring for the patient. And we have to understand that in pregnancy and lactation are important issues in the management of MS. So these are generally well tolerated after the immune system has been reconstituted, and the same cannot be said when the patient is on continuous immunotherapy as he would be on in escalation therapy. Thank you.
Okay. So let's hear the other side of the story as well. Who's coming on board?
Very good evening, ma'am.
Yeah, welcome, Abeer. Come on.
Is my slides visible?
Yes, doctor. Your slides are visible, sir.
So going ahead. So first, I would like to clarify about something about MS. So my outline would be first deciding about disease heterogeneity. What is escalation? Is there any evidence for escalation? And time is the key. So MS is still an enigma. We are still not really sure how MS works. What is the pathology? So there's, unlike other autoimmune diseases, there's still a heterogeneity in the pathogenesis of MS. There's a genetic heterogeneity for susceptibility as well as for the outcome. Thus, we have a different outcomes even with the different DMRDs what we have. Even for a clinical course, we know 85% present as a clinical isolated syndrome. About 30% of all those patients stay as benign MS, defined as EDSS less than or equal to 3 after 10 years. Even at a German MS registry of 31,824 patients, 42% had shown a benign MS. And even when we have a rigorous definition of benign MS as EDSS less than 1, even 13% of them remained benign. So are we really justifying in giving a blind treatment of induction right at the start? So before that, what is escalation? So as per the definition of escalation, escalation is based on a reasonable decision making procedure in which drugs with the best risk is to benefit ratio are first preferred, and only if needed, drugs with the increasing power or toxicity are successfully adopted. So as we can see, the common model for the escalation, we start with a first line therapy, that is glatiramer or interferon. Then we go to more aggressive therapy of fingolimod or dimethyl fumarate, and then we further switch to natalizumab and further B cell depleting agents. So this will obviously discourage us from using a first line agent, as we can see that the AR risk is much better when we compare the second line agents compared to the first line agents. But if we closely analyze this is a very beautiful paper just telling us about the number needed to treat to benefit. Now, if we see for the interferons, it is almost comparable to natalizumab. So are we really going to depend on ARR and the efficacy, which we saw in the previous slide? Also, as we had talked about, the best benefit is to risk ratio. If we can see, the interferons have the most favorable benefit to risk ratio among the first line treatment, and natalizumab being the most favorable benefits to risk ratio in the second line treatment options. Even now, what evidence do we have for the first line? Now, conversion to secondary MS, even if we see that compared to no treatment, glatiramer or interferon when started delays the conversion to second line treatment. But here I would like to focus on one point, the time to start. Now, if we start before 5 years after the onset of MS, definitely it has a better improvement, better outcome than after starting at 5 years. So time is brain is not only limited to stroke. We have now the new concept of time is neuron. As we can see, the earlier we start the treatment, the better outcome we have. So with a hazard ratio of time to irreversible EDSS 6 from the treatment start, which we can say is inversely proportional to the delay in time. Also, we have now a follow-up study of beta interferon, in which we can see the survival also depends upon the long-term effect of beta interferon in the form of cumulative exposure, as well as when do we start the beta interferon. And if we compare it with the other DMTs, it is pretty good in the long-term survival as compared to other DMTs. So what the evidence we have for switching? So for switching, when we see, if we switch from interferon to the same category, interferon to interferon, after switch, there is an improvement, but a very slight improvement. But if we hike up from interferon to mitoxantrone, we can see that there is a definite, a very considerable improvement in the efficacy from 33 to 81%, which we can also see in this graph, in which this dotted line, the red dotted line are the higher efficacy, and the green dot and the black dotted line is a medium efficacy. So if we can see, the relapse-free survival is better if we switch to higher efficacy drugs. So the treatment escalation leads to fewer relapses compared with switching to another moderately effective therapy. Escalation from glatiramer to fingolimod, again, I would like to focus on the point that time is more important than the type of drug in which you are escalating. So timely escalation is much more important than induction therapy. So, and even if we escalate, now this clearly tells that for the relapse and for the adverse event, natalizumab and rituximab are pretty good. But for the medication persistent, because of the side effects of natalizumab, rituximab holds much higher than natalizumab and fingolimod. So as my friend clearly told us about this paper, one thing we forgot to see was adjustment for the relevant covariates. There was no difference in the hazard of SADs between the groups. So what is the take-home message? Still, we are learning about the MS. Still, we need an individualized treatment. And still, early treatment is the key, irrespective of what drug you are using. As really shown in the guidelines, as shown in the EN guideline, which says that offer interferon or glatiramer acetate with a CIS. Second, for active RRMS, go for individualized therapy. Even for the practice guidelines for selection of DMTs in multiple sclerosis by consortium of MS centers, it also tells, it recommends to advance to a perceived higher efficacy agent in case of any relapse. Thank you.
Great. So what I'm going to do is to really summarize in 2 minutes what you both said. And then I'm going to give a chance for both of you to, you listen to each other and then you come to rebuttal. So there's one thing which both of you said the same. It was the same language where you said that yes, multiple sclerosis is a spectrum. It's heterogeneous. So obviously one glove fit all approach is not going to be applied. Said that there are also levels of multiple sclerosis, or I should, the other way to say is that there are levels of treatment. There's level 1, level 2, level 3, and level 4. So it's a level 1 where you have the interferons, the glatiramir. You also have dimethyl fumarate and teriflunomide. A little above is actually dimethyl fumarate, but it is still clubbed as level 1. Whereas in the level 2, you have natalizumab and fingolimod. You probably have rituximab somewhere hovering around that. And then you have ocrelizumab also hovering around the same way. And then you're going to level 3, wherein you're looking at the immune reconstitution therapies, which include, you have the finite treatments, like you have cladribine, you have, the specific, then the non-specific ones, the alemtuzumab, or you look at, the mitoxantrone, and then you have the bone marrow transplantation, right? So you have several levels. And the reason that you need to, in a particular given point of time, which patient will require which level of treatment. So keep that in mind. And you also have the classic, the modified Rio scores, and you have other scores, which actually give you the indication and the parameters to tell you to shift your gear. And there is also now, as Abeer said, adequate evidence that it is no good shifting laterally. You need to shift vertically. Even if you have to switch, there's no point getting into interferons to glatiramir just because they, operate in a different mechanism. You're going to switch vertically. So there's a lot of evidence now. In fact, it's an old story. Keep this in mind, and also keep this in mind that there is, as Abeer said, there is a number needed to treat and there's a number needed to harm. And that's actually we brought about, in fact, both of you have not mentioned about 2 big meta-analysis and a Cochrane review which has been published, one in 2016 and the other in 2018, which compared and contrasted all these different therapeutic regimes and gave a beautiful diagram and also a color-coded levels, wherein you can simply see as to what is the type of patient you're looking at and where should they go. And as you rightly said, time is neuron, depends on when the person has come to you. And also you need to discuss what is an aggressive MS. So are you going to deal with an aggressive MS the same way as you deal with a CIS? So keep all these things, and I'm going to give a chance for rebuttal. Pranjal first.
So coming on to rebuttal, the efficacy of induction therapy has been established beyond doubt, but the contention remains, how safe are these drugs? So let's take a look at the safety profile. So in this, we can see that when these patients who had received alemtuzumab were followed up to 12 years, we can see that the adverse events, whatever were there, were actually front-loaded. And as the time passed by, these adverse events came down. The most common adverse event which we see, that autoimmune thyroid disorders were practically zero after in the 10th year, 11th year, or 12th year of therapy. And also the side effects which were there, like infusion reaction, were quite manageable with either using methylprednisolone or antihistaminics. So this was again a network meta-analysis which looked at the acceptability of various disease-modifying agents. So we can clearly see here that the patients, the Sucra score for acceptability for alemtuzumab was much higher in these patients as compared to patients who were on interferon, glatiramir acetate, or dimethyl fumarate. Similarly, this study looked at the patient's quality of life when they had received alemtuzumab and had autoimmune thyroid adverse events. So this study showed that the thyroid problems did not make the quality of life worse, and even when the problems were ongoing, and had minimal impact on the health-related quality of life in patients treated with alemtuzumab. So these were quite well received by the patient. This was the safety data for cladribine. Premier registry is a registry which maintains the data for patients who have been treated with cladribine. They do have long-term data, and they've concluded that malignancy, which was initially a concern with cladribine, did not show evidence of increase compared to placebo-treated patients. And also there was no increased risk in infections except for higher incidence of herpes zoster, which was not systemic serious disseminated herpes. So it could very well be managed with using managed with acyclovir. Similarly, hematopoietic stem cell transplantation, initially the mortality rates were quite high, but after post 2005, we can see that the mortality rates have come down significantly because we become wiser in our patient selections and the kind of regimen we use for myeloablation. So the mortality rates have come down. And also I would like to point out here is that these patients who had higher EDSS scores had higher mortality as compared to patients who had lower EDSS scores. Again, reiterating the fact that these therapies need to be started early in order to have better mortality outcomes. So a patient of aggressive MS can have really bad outcomes within 5 years of onset, and our ability to pick up at the onset of aggressive MS is average at best. Known risk factors like male sex, early onset of disease, or motor relapses, motor presentations, they account for small part of overall risk in an individual patient. And the R square was 0.35 in a study of 8-year follow-up, as compared to side effects which are manageable if we are vigilant enough to pick them up early. So it's a trade-off I'm willing to make for a patient rather than pushing them to a crippling disability where they become urinary incontinent or worse, cognitively impaired. So one important tenet of escalation therapy is, as Dr. B said, that it is easy to escalate. I don't think so it is easy to escalate, because are the patients really doing well and are we monitoring them right? Perhaps no, because routine imaging modalities are not sensitive enough to pick up the ongoing activity. In practice, brain volume and white matter structure integrity are seldom monitored, and brain volume and brain atrophy, a component of NIDA4, relates with cognitive dysfunction and leads to long-term disability. And clinically, we depend on EDSS so much, which has high inter-rater and intra-rater variability and lays too much emphasis on ambulation and completely ignoring other aspects of MS, which do contribute to long-term disability in MS patients. So this is a topographical model of MS, where you can see that these peaks were clinically manifested after they had crossed the clinical threshold, whereas these subclinical peaks never got manifested, even with the best imaging MRI modalities with 7 Tesla MRI. Also 20% of these lesions will not get picked up. So these subclinical lesions, they go unaccounted for and they contribute to disability and disease progression. And the way we follow a patient leaves a lot to be desired. So this was shown in the study where association of initial DMT with later conversion to segmentally progressive multiple sclerosis was shown, where these patients who were started on high efficacy therapy like fingolimod, alemtuzumab, which is an induction therapy, was significantly lower, the hazard ratio of getting converted to SPMS, as compared to patients who were started on glatiramer and interferon. So one might argue that these drugs are really expensive, and are they really worth it? The cost effectiveness could be an argument. But I would like to mention here that multiple sclerosis is prevalent among working age individuals who are from between the age group of 20 to 60 years, the most productive time period of a person's life. And a recent survey concluded that 60% of the patients were not working, 50% have received disability benefits, and 27 patients reported missing 6 days or more of work in a year. Add to that the long-term therapy cost of continuous immunosuppression, cost of hospitalization, the management of relapse, all add up, and we never account for that. We have to do that. And also rituximab, when it came in the market, Tecfidra were 38,000, 80,000 rupees, but as the patent got over, these costs have come down. So we as clinicians need to embrace induction therapy, and I'm sure the pharma will follow. So to conclude, adverse events are front-loaded, but they are manageable if you are vigilant enough to pick them up, and thereafter they decline. Escalation therapy may not necessarily be safe, as the adverse effects tend to be cumulative and increase with time. And escalation therapy, escalating the drug, defining suboptimal response as to when to switch is not easy and that straightforward. And in the long term, escalation therapy may not really be that cost-effective. Thank you.
Thank you, Pranjal. Very forceful. And yeah, Abeer, come in.
Thank you, Dr. Pranjal. So before going ahead, I would like to question everyone, do we really understand the concept of induction? So what is the ideal induction therapy? Now, ideal induction therapy is hit at the first strike. So a sharp shock treatment, restricted adverse effects, leading to long-lasting disease-specific immunological tolerance, and leaving the remaining immune system competent to fight off infections, and the patient is free of risk. So are we really dealing with the proper inducing agent? Before that, do we really understand MS immunopathogenesis? As I started my presentation also, immunity is not always harmful. As we have seen in many papers, immunity can be helpful. We are actually talking about remyelination. Our target is remyelination. We know CD4 T cells, they induce microglia to secrete IL-12 inhibiting agent. macrophages, they remove the myelin debris, then only we'll have the remyelination. So are we really comfortable in wiping off all the immunity at the first go and not taking a shot at remyelination instead of immune modifying therapy? Are we really comfortable in giving an immune depleting therapy? So one thing we need to understand, aggressive therapy is not same as induction. As initially the induction, there's a confusion that is natalizumab also a part of induction therapy. As we say natalizumab, after discontinuation of natalizumab, there is a chance of rebound phenomena. So if we say that for the induction therapy, as Dr. Pranjal already showed, fingolimod and natalizumab, they have no induction effects. Only we have rituximab, that also is not really proven for MS, but alemtuzumab, hematopoietic stem cell transplant, cladribine and mitoxantrone are the strong inducing agents. So again, benefit is to risk therapy, I've already shown. And as we can see, the alemtuzumab, the main inducing agent, what is being contested now, has a very high NNTH as compared to the other agents. And as we can see the study, as Dr. Pranjal had also shown, the 12-year follow-up of the CAM S223 study, what we first need to understand is that most of these patients, about 33, every 3 in 10 patients had required an additional course. So it's not only the one-time therapy, it's not only 2 injections, it's not only 2 pulses. 33% they required repeated doses, and infection rate still is persisting throughout the follow-up study. Agreed, the autoimmune, the thyroid or side effects, they persisted till 4 years. But if we start giving the therapy again and again, if we start giving the pulses again and again, these side effects will come back. As we can see, even for the 9-year follow-up of CARE MS1 and CARE MS2 study, in these, this is actually, you can say, very much like a induction versus escalation. In this, initially the patient was escalated to alemtuzumab, or induced with alemtuzumab, or the patient was started with interferon and later escalated to alemtuzumab in the follow-up study. So what we can see here is, in the follow-up of CARE MS1, as we can see, even at the 9 years, be it induction with alemtuzumab or be it escalation after interferon, the end result, there is hardly any difference in 6 months CDW at 9 years, also 6 months confirmed disability improvement. Though you may argue that there is a difference in CARE MS2, but why is that? Because those people, they did not really escalate. Even after the failure of therapy of interferon, for 2 years they continued giving interferon. So they did not really escalate to alemtuzumab in the first go. Similar thing for brain volume data, the main part of our NEDA. As we can see, even at 9th year, there's hardly any difference between the 2 therapies, be it an escalation or be it an induction with alemtuzumab. Though again, there's a difference agreed in CARE MS2. So coming back to again this efficacy and safety, as we can see the follow-up studies of these, we definitely have throughout these 9 years, we have serious infections being in 6% or 8%, and also the thyroid side effects has already been mentioned in the previous study. So again, is alemtuzumab the ideal induction therapy? No, because as we have already told, the ideal induction therapy has to be one go. Alemtuzumab needs repeated infusions. And also alemtuzumab, with every repeated infusion, it's associated with again a heightened risk of side effects. So do we have, what is the evidence of induction? All the evidence for induction, everything deals with small sample size. They have a short follow-up. Role in early MS is not clear. Everyone is dealing with the aggressive MS. But what about the early MS? Are we really comfortable in using inducing agents in early MS? What about the risks to benefit? What is the cost of this induction? What about the risk of side effects and infections to the patient? And actual cost of the treatment. We cannot really depend on future to bring down the cost, especially in our Indian setup. As we can see, the first line therapy, monthly cost is 11,000, 12,000. Definitely Tecfidera after losing the patent has become affording by the patient. But what about natalizumab and alemtuzumab? It's way higher than what me and you can even imagine. Also, now we are living in a COVID situation. We are actually also, COVID is one infection. We may also in future get some other infections. Hopefully not, but we may. So even in the COVID infection, are we really comfortable in giving these higher inducing agents? So as given by the consensus statement, by even Padma ma'am, Khurana sir, and Rohit Bhatia sir, they do not really advise using alemtuzumab, rituximab, or fingolimod, though natalizumab can still be used. But the ideal inducing agents, can they be used? No. Which is also seen in the consensus statement internationally. The treatment with alemtuzumab, cladribine increases the risk of SARS infection. Treatment any B cell depleting therapies, even mitoxantrone or even the bone marrow stem cell transplant, they also increase the risk of SARS infection. So in the end, what I would want to say is, with great power comes great response, comes great responsibility. So are we really comfortable in subjecting the patient to side effects which we are still looking into, rather than helping out the patient? Thank you.
And another forceful rebuttal. Okay, I have one question for you, Pranjal. So if you have a patient coming with classic CIS, will you advise alemtuzumab to that patient?
Ma'am, so I would look at the lesion load. I would look at the features which could predict.
So it's a CIS, and she has, you certainly will have to start a DMT. Okay, it is clinically isolated syndrome, and that one of the part of the definition is that there is a load in the MRI. And okay, let me put it this way, that you have lot of load in there and lot of, enhancing lesions, big lesions, but clinically she is CIS, and she's probably EDSS maybe 0 or 0.5, and she's not on DMT. So you want to start, would you start on alemtuzumab?
So first thing is that the patient has a lot of load and there are a lot of enhancing lesions. I would tell her the data and try to assess her preference, because MS treatment eventually doesn't involve.
Will alemtuzumab figure into the discussion?
I will definitely, ma'am. Because
okay, let's just leave it at that. Abeer, question for you. So yes, you have a young man who's got a symptomatic disease, in the sense has a brainstem, has cerebellar involvement, has a spinal cord, has been given steroids, little improvement, lot of disability, came with just 2 attacks in a span of maybe a month, and has come to you with classical MS. What would be your first line DMT in such a patient? He's a young man.
Since this man qualifies for aggressive MS, I would like to start with the aggressive therapy only.
Which one?
I would like to start with either natalizumab or rituximab, but alemtuzumab again.
No, one moment. I'm not talking of alemtuzumab. My question to you was which treatment? Okay. So now we have from both of you is that you judge a patient's management strategy according to, number one, his clinical presentation. Then you add on the other material that you have into your evidence, which includes the neuroimaging, which may include even other biomarkers, which you may have even in future, because MS is classically now being described as a personalized and precise medicine, right? Again, the same thing, one glove fit all approach doesn't work. So it will be very precise and personalized. And we're not even talking about the cost here. And we're not talking of India. We're talking of pure science in a state of utopia. Okay? All right? Let's not get cost. So, said that, now, when you're talking of induction, you're not talking only of alemtuzumab. Alemtuzumab is not sine qua non to induction. Induction therapy is immune reconstitution therapies, wherein you have specific, you have non-specific, in which you have the so-called, kind of, what do you call that? Instead of this continuous treatment, you have a time limited, so-called time limited. As Abeer said, alemtuzumab is not always 8 doses. Sometimes it goes on. So therefore, in that you have cladribine, alemtuzumab, and bone marrow transplantation, and a little below maybe rituximab. Certainly, fingolimod and natalizumab don't come into that category of induction at all. So maybe the debate should be more of, one is to when to start the treatment and what would be the medicine to start, instead of delaying the treatment like it used to happen, that you have a CIS, then you debate and then you decide and you say, it doesn't matter, one optic neuritis, we'll wait for another thing to happen. And this has happened. And even and it persists to happen amongst neurologists as well. Forget about physicians. So that you should never do. And both of you agree on that, isn't it? And number two is a choice. It need not always be interferons or glatiramide. It can still be a natalizumab or a fingolimod, depending upon how aggressive the multiple sclerosis is. And Pranjal, we may not be able to predict how they do, but we still have parameters which you can reasonably corner in what is called as an aggressive MS. You can easily do that. So probably the giving the management depends upon how you design for that patient. But I guess starting alemtuzumab to CIS, maybe it's a way bit too stretched out, Pranjal. I don't think we would all agree with you on that, because alemtuzumab, all said and done, even in the best of centers, even when you're talking about Switzerland, wherein you have the highest number of guys on alemtuzumab, it's basically it's a Europe-based drug, and you have the highest number in UK and in the rest of Europe, and predominantly in Swiss. Even there, they will not start alemtuzumab as a first-line drug, in patients coming with a CIS. So they may be looking at it in a very aggressive MS, wherein they have an opportunity. There, Abeer, yes, there are cases wherein people would prefer to have so-called, a finite, when they say it's a finite treatment. Finite in the sense, okay, this year I take 5 and the next year I take 3, and so be it, God willing, that's where I stop. And that's the reason you have so many people who want to come and get a bone marrow transplantation in spite of doing well, saying that it's a finite treatment. I don't want to be on this oral medicines or on, in the drugs. So one of the things which is against, unfortunately for our escalation, is the infinity of the treatment. We don't know where and when to stop. So I think both of you have done extremely well. You've done a great literature survey. Both of you, in fact, have won in my heart, and I'm sure across the board, because both of you are right. The only thing is, Pranjal, don't talk about alemtuzumab in a CIS patient. But yes, it comes on board when you have an aggressive MS. And again, it's a personalized treatment. Please remember, as Abeer said, that is a take-home message. Time is neuron. Don't waste time in starting a DMT once you have a diagnosis. The early, the better the patient would be. So I think, have we overstepped the time? I think we have. Sorry, Anand. I think Anand, are
Yes,
you
ma'am.
monitoring this? You are looking
Yes,
daggers at me. Sorry, but you see, I had big guns, Rohit there and Professor Lal sitting there. So what could I do? So I tried to do.
Thanks a lot, ma'am.
Rohit, was it all right? Do you agree with what I say?
Oh, yeah, absolutely.
Okay, all right.
Thank you, ma'am.
Okay. So do we have, is that it? Can I log off then? Is it over?
Ma'am, please stay for the question and answer session.
Okay.
As we all know, one day with a great teacher is better than 1,000 of days with diligent study, and today's session is a testimony. This is the prize which the participants will be getting. The book by Dr. Kameshwar Prasad, Evidence-Based Medicine. I congratulate all the participants for the same. And I hand over the proceedings to Dr. Priyanka for question and answer session. Thank you.
Thank you, Dr. Anand. And thank you, ma'am, and thank you, sir, for such a great session. And we have 5 minutes left, so let's make use of it. Sir, so one question from the audience directed to you, Professor Rohit Bhatia, sir. Question has been asked. Am I audible?
Yeah.
Okay. So question has been asked by Dr. Sarath from PGI Chandigarh. So the question is, can MOG antibody positivity be given equal value as anti-echoporin 4 antibodies in IPND diagnostic criteria?
Yeah, so as far as the diagnostic criteria go, they have been laid for an NMO spectrum disease in general, but they are more specifically tuned towards aquaporin 4 disease, because these criteria are specifically for defined clinical syndromes and defined clinical syndromes under the aquaporin 4 seropositivity and negativity. If you ask me pragmatically, can we replace it with the same, with the same strength? Yes, if you see a patient with a specific syndrome and it fits into and he or she has MOG antibody positivity, we should give that the same value. If you go by the strength of evidence and the linearity of association, the aquaporin 4 has much strength of association in the diagnostic grid over the years compared to MOG antibody, where it becomes more heterogeneous. For me, if there is a patient with a syndromic opticospinal syndrome and it's MOG positivity, for me, it's the same value to treat this patient long term. I won't really differentiate whether the patient is aquaporin 4 or MOG positive, because if I'm looking for a biomarker and I'm finding a biomarker, then I need to, I need to respect that biomarker. And with the lineage of understanding over the last about maybe 5 or 6 years, we've come to know that it can behave badly as aquaporin 4 as well. But so I think we can't replace it because the criteria are designed for aquaporin 4 disease. But yes, we must treat with the same strength.
Priyanka, with your permission, can I ask a question to Rohit?
Yes, ma'am. Sure, ma'am.
Okay. So now that we actually know that this is Rohit, you have all
Yes.
these antibodies described, and also what about the IgG4? That spectrum, IgG4, IG1, G1, like you have, say, IgLON5, the one with the sleep syndrome with encephalitis, or even the DPP4 or whatever it is, like the other encephalitis.
Myasthenia gravis.
So where are you categorizing these? Because all of them are so-called immune spectrum. Will they also be now put into this spectrum? The enlarging spectrum we will also be talking about these someday in one continuous spectrum, the way we are talking about the others.
I think it's absolutely correct perspective, ma'am, that we at some point may need to make them as a continuum, but I guess they will be more specific to the phenotype of the disorders as well. Because when we talk about an opticospinal syndrome, we typically mean someone presenting with a cord or a vision involvement, and that's where you unify these patients into one category. But the other disorders, as you rightly mentioned and brought into IgG4, now people started IgG4 with one particular entity, but now we know that it's a systemic disease and we can actually have any part of the organ system involved. The same thing happened with aquaporin 4 disease. People found that it is associated even with patients with myasthenia gravis if they are positive, and other common associations. They're not common, but they do exist. So I guess we may be able to unify them based on the general presenting features, but they will still be segregated because of their phenotypic differences. I mean, the story of autoimmune encephalitis perhaps started the same way, like an NMDA receptor typical syndrome. But now whenever we see a person with a psychiatric or a behavioral syndrome, we'd never say it's NMDA receptor alone. We say it seems to be an autoimmune encephalitis. Maybe when we dissect their clinical phenotypes, we'll realize some people with neuromyotonia could be Casper2, some people with normal MRI, maybe more NMDA receptor. So I guess, as you rightly pointed out, we are learning to understand the continuum of autoimmune neurology by these antibody-mediated diseases. But somehow or the other, there are subtle phenotypic differences which will help them club together. So we're probably going towards that direction.
Thank you.
Thank you, sir. Thank you, ma'am. So we have lots of questions coming up from the audience. We cannot take up all of them because of paucity of time, but I would like to assure the audience that we'll be mailing them the response as soon as possible. So I'll be handing over to Dr. Anand now for closing today's session. Dr. Anand, sir, please.
Thank you, everybody, for participating actively. All the consultants, the senior residents as well. I hope you will join us again tomorrow for the same. Thanks a lot, everybody.
Thank you very much. Good night, sir. You almost slept, though.